Right. I'm Mark Owen and Julie Fallhaber from Blue Cross Blue Shield of Oklahoma. We also decided not to take the 5 questions exactly. We've broken in our answers to address those into 3 categories. One is just a little bit about our background expertise in this business. Second, we want to talk about outcomes. And the third is really about how providers can win in our view and our experience. So from an experiential standpoint, the folks that are part of our Medicaid business, collectively we have more than 65 years of experience in dealing with the Medicaid populations across the spectrum. So the duals, the disabled population, the families, the kids, many people with special needs. So I think we can safely say we've experienced it all in one way, shape, or form. And one of the key things that I would tell you about our people and our approach is we're very passionate. People that work in this business, I think it's probably universally true across the industry, whether it be on the provider side or the plan side, but I personally can say I've never worked with a group of more passionate people about making a difference in the lives of the population we serve. We also believe that, and as a personal belief I have, healthcare is local. And so you can't come in and say that what works here in someplace else is going to work here. You got to approach it in the community. And Julie's going to spend some time talking about how we approach that. But essentially, we really think you've got to make it fit for the members primarily, their family members, but the providers as well. As Blue Cross Blue Shield of Oklahoma today, we serve the entire state. So from our point of view, serving this entire state from Medicaid would fit with our overall mission, and it really depends on how policymakers want to go forward. We would work with them to make that happen.
And like our colleagues, we have similar programs in place to deliver our outcomes and really focus on that broad community support. So working with providers, state officials, community organizations, the tribal organizations, and again, kind of looking at that whole person for their care. And to help engage members, sometimes our members are difficult to engage with. We work with local community health workers, other community-based organizations, and once we do get in touch with them, for a lot of our members are pretty high risk, and so kind of broad high risk population. We do care coordination, local care coordination, where nurses and social workers who live in the community as the same as their members go out and do health screenings as well as environmental screenings in the members' home to help them build that medical, social service, and community-based plan, working in conjunction with the providers in that area as well. And looking at that, we were talking a little, I think, some of the stories about in lieu of services, and services where we put things into place that make more sense necessarily than a traditional healthcare cost. And a story we have is about a member of ours with pretty serious behavioral health needs called up our offices really concerned about the fact that he was $25 short in making his rent. And he had been late on his rent before. He was really concerned about his ability to maintain his home environment. And clearly, when someone becomes homeless, their health care diminishes really quickly. So the care coordinator that had been working with him was able to reach out to community resources, a community charity, find that $25, call up the landlord, assuring the $25 was forthcoming, and kind of stabilize this member in his health. The member wasn't super engaged with the care coordinator up to that point, and especially not going through a lot of the physical health care screenings that we really wanted him to be able to do to balance some of his behavioral health concerns. And since that time, he's been much more engaged through that process since we were able to provide that in lieu of service for him, kind of providing the right care at the right time, at the right cost. The $25 that we invested, actually we didn't invest, but the community invested in maintaining him in his home environment far outweighed the cost that would have been occurring had he become homeless. So through this community-focused integrated approach, we've been able to substantially reduce costs by reducing emergency room visits. In one of our states, 12% for frequent utilizers and 16% for those with behavioral health issues who've engaged in the behavioral health care model. And we also been able to decrease hospital admissions for behavioral health conditions 9%, again, after engaging in behavioral health care management. That's so the integration of behavioral health and physical health care is so important, as our colleagues have mentioned, and we're really focusing on that with our populations.
So the last category of how do the providers win, or can they win? And I think the answer is yes. Our general approach as an organization is to work with the provider community. They're not always, they're not ever at the same place in terms of their capabilities or willingness to accept risks. So we can start as basically as a fee-for-service contract with them with outcomes incentives that align the things that need to happen from a member outcome perspective, but reward the physician or the hospital for delivering those things. And we try to help them move as quickly as possible to outcomes-based reimbursement for risk, share, risk, or full risk, if that's what they want. So again, it's not a one-size-fits-all. We think, and again, this is through our experience, that there are opportunities for, in a move like this, for the hospitals in particular, to maintain their level of reimbursement. There are obviously the issues with the upper payment limit if you move from fee-for-service. But a good example, since Florida was here, Florida was successful in setting up a waiver program and in fact increased through that process the pool of money that was available from about $600 million to $1 billion through the waiver they got with the federal government. So there are lots of options, and so we like to work with providers to help them understand those options, work with the state and providers then to find a way to make sure that the payments are adequate to provide the care that's necessary for these people. So that, I'm going to turn it over to.
Thank you. Good morning, I'm Leanne Behrens, and I am the president of the Amerigroup Health Plan in Texas. And I was very excited to come up here to Oklahoma because I grew up in Oklahoma. So, in fact, I graduated, I was going to tell you when I graduated, but then Speaker Cannon mentioned when he graduated from law school. I thought, no, I'm not mentioning that now. It's feeling really old. Anyway, I grew up and graduated from Mustang High School and still have family in the area. So I'm very excited to be back in my home state and to talk to you about my experience in Medicaid managed care in Texas. Texas has been doing Medicaid managed care since 1996. I've been involved in it since 1998, and it has certainly evolved. And Texas, I think, has been very, very progressive in their approach. They, from the very beginning, put all populations into managed care. They didn't divvy it up, they didn't do TANF and not do SSI, which I think is a smart approach, because quite frankly, most of the spend that you have in your Medicaid program is focused on your SSI members. If you leave them in traditional fee-for-service, you're going to eliminate your ability to save the most amount of money in terms of moving to Medicaid managed care. And I manage about 700,000 members in Texas today. I have about 1,000 employees, almost half of which are clinicians, doctors, nurses, social workers, very heavy on that side. And we operate pretty much across the state, rural as well as urban. The rural area is one of the last areas that Texas rolled in, kind of the old myth being that you can't do managed care out in the rural area. And I just don't think that's true. You can set up and function just like you do in the urban areas, even in those rural areas, and we've done that across the state of Texas. As I'm not going to tell you stories because you've heard lots of stories today, but as I was sitting here hearing what everyone else was talking about, I think there are three primary audiences that you need to consider as you're thinking about Medicaid managed care. The first is obviously the state of Oklahoma. What do you bring to the taxpayers of Oklahoma as you consider that option? The second are your provider community. How do you ensure that they are part of the solution? And the third area are your members. And so I'm going to kind of talk about each of those and what I see as the solutions for those. In terms of the taxpayers, there is no doubt that Medicaid managed care brings almost an immediate savings to your bank, so to speak. And not only do you get that immediate, I think in Florida they said it was 5%. Texas does a Medicaid managed savings off the top. It's usually they start out at about 10%. So you get that immediate savings. Then you get what I like to call kind of bending the cost curve, right? In a traditional fee-for-service, you can see your trend line. You see it every year, it's going up, I promise you that. When you start bringing managed care in, we don't eliminate it, we can't eliminate it, but it certainly starts coming down. The cost curve is going to bend for you. And so I think you have immediate as well as long-term. There are a couple of issues that have been mentioned in terms of the state. How do you ensure quality? Texas is, and I'm not sure I necessarily agree with this, but I'll tell you what Texas does. I have to live with it, so I'll tell you how it works. Texas puts 4% of my premium at risk to hit quality measures. 4%. I only want about a 3% margin on this business. So, I have more to lose if I do not hit certain quality measures. So there is certainly a way that you can do that and do it effectively. In addition, the state of Texas has what's called an experience rebate, which many states are moving towards. It's in effect a profit share. If a managed care company hits a certain level of profit, they start sharing that back with the state. So it guarantees you that my profit is not ever going to be out of line from where you want it to be. You in effect manage that from your end. So that's kind of what we do for the customer of the state. In terms of providers, we have a lot of flexibility. And someone mentioned that providers are at different places. Some are all in, give me 100% risk. Some are like, kind of help me figure out how to do a medical home model. And really, we can do that whole spectrum. We do a number of different things. We have a great partnership right now with UT Physicians, which is a huge group in Houston, as you can imagine. It's associated with the medical school, about 600 docs that we do a lot around their primary medical home. We help them set it up. We brought in the practice specialists so they could become what they wanted to become. We actually put people in their offices, including a behavioral health specialist, to screen members who come in for behavioral health needs. Because what you will soon discover, if you haven't already, is that there's a lot of dual diagnosis that happen in this population, particularly within your SSI population. Well over probably 70–80% have some kind of a behavioral health need. If you're not addressing both of those needs, you'll never get to where you want to in terms of saving the dollars. So lots of opportunities with providers. We do a lot of gain share, a lot of quality indexes with providers. Last year, to physicians alone in the state of Texas, we distributed back over $1 million in quality incentive money. So there are lots of opportunities. We are looking at a number of hospital systems today that are wanting to take full risk. That's the model they're wanting to move towards, and we're certainly open to that. So I think the provider community is your second functional area. And then finally, obviously, is your member, and you've heard a lot about members. There is no doubt that Medicaid managed care is more flexible than traditional fee-for-service. We have the opportunity to look at data. We can do projections on who is going to end up in the hospital, not who has ended up in the hospital. We do a lot of projective modeling. We have the ability to reach out to members, to incentivize members, to provide opportunities for members to control their own health care needs. And that's kind of what it's all about. I think a lot about my own self, and probably everyone in this room. You have health insurance. Your health insurance company may have reached out to you to do something before. I have a child with asthma. They call me all the time about wanting to put him in a disease management program. And you know what I do? I don't answer the phone or put the mail in the trash. Now tell me you don't do the same thing, right? Why are Medicaid members any different? They're not. They're not going to pick up the phone and talk to you. You have to give them a reason to do that. You have to incentivize them. You have to make it easy and flexible for them to do that. So there are ways to work with the population to ensure that you get the outcomes that you want. You can reduce emergency room. You can reduce inpatient stays. You can reduce length of stay. All of those things are possible, but it is absolutely a collaboration with the member, the health plan, and the provider to get there. So I think as you're thinking about reform, you have to think about those three legs of the stool. How do you help the state, the taxpayers? How do you help the provider? And how do you help the member? And when you're looking at those three components, then you will come up with a winning solution in Oklahoma. Thank you for inviting me.
Questions, anyone?
We bored them to tears.
Thank you all.
Thank you. Thank you.
Okay, so our final conversation that we're going to have with you is about the politics and the policy of Medicaid reform. And I know there are a couple folks from the executive branch in the room, and so I think that this will be particularly insightful because our two presenters are really, excuse me, speaking from the perspective of Medicaid directors or folks working in the executive branch on policy, and can really talk to you about going through the reform process from that perspective. First, we have Mark Trail, who I'll just briefly tell you about his background before I turn it over to him to talk. He ran the Georgia Medicaid program for 8 years, served in Georgia government in a variety of levels, including mental health, Medicaid, in the human services field for 32 years. And then for the last 5 years has been working directly with state governments as a managing partner of Health Management Associates as a consultant. And so lots of different perspectives, not only within Georgia with implementing reform and helping patients, but also with helping states go through this process. So Mark, talk to us about the politics and policy of Medicaid reform.
Thank you. I think I need this mic right here. It is my pleasure to be with you all today. Can you hear me okay? There we go. All right. So if we get that driving right here, Jonathan's going to drive for me. I'm really mostly going to come here and talk to you today about Georgia's experience. Interestingly, one of the gentleman's comments earlier from Florida was that you already have an example of a pilot in Florida and their movement towards managed care. I will offer, with some humility, that actually they copied us. So you're going to hear many of the same themes, but I think the important point to that is that those themes are things that work, and they work based on actual experience, and they work in many different environments. So I would offer to you that Oklahoma can learn many things from other states, even though every state does have its unique characteristics. All right, so next slide. So some of those of you who maybe have gray hair remember the game Pac-Man. It was one of those games where a little thing goes around and eats the little balls. Well, Medicaid has, I remember being expressed as it was the budget Pac-Man. It was certainly happening in Georgia in the early 2000s. We were experiencing that approximately 40% of all new revenue coming into the state was going to the Medicaid program. I remember sitting down with then Governor Perdue, and he says, Mark, he says, I understand health care costs more year over year. He says, but I cannot have it growing at a rate faster than revenue coming into the state. And you think about that, that makes a lot of sense. You have to be able to afford other things, and you can't have Medicaid crowding out the other things that are important for a state to do: education, public safety, transportation, economic development, and so on. So as a result, we had to do something. And so we took a look at managed care and learned from, we did an RFI, request for information. We learned from other states as we were preparing to think about this. We learned from providers. We learned from a number of organizations. And if you don't mind going to the next slide. Basically, there's really 4 things that cost money in Medicaid. It's the people you cover, the services you cover, the price you pay for those services, and how much of those services do people use. And that's, at a very simple level, pretty much it. Well, as we looked at that and we learned from others and considered the fact that Georgia already had a pretty conservative threshold for eligibility, so there wasn't much to be done there. We also had pretty much the basic services, and when you consider the non-essential basic services that were optional that could be cut out, it actually accounted for less than 1% of the total budget spent. So there really wasn't much to do there. Price has a break point. I had also the responsibility to make sure we had access for our patients, and price is very important in that. So Georgia actually has retained a very reasonable Medicaid price rate, I would say. We're at about 90% of Medicare, for example, with the exception of the new primary care stuff, of course. So the final thing was utilization. So what can be done about utilization? We tried several things at our level, at the state level. but really didn't have, number one, the expertise within our own staff, and number two, the resources and tools to be able to do the right things with utilization. So moving to the next slide. Our experience in managed care, like so many states, had evolved over the years. In the late 1990s, we actually did make an attempt to go to full risk managed care. And understand when I say managed care, primary care case management, like I believe you do here in Oklahoma, is considered managed care, but I'm talking about risk-based managed care, just to be clear. We had made an attempt to do that. We did it on a voluntary basis. We had 3 plans in the state, and at its peak, only about 60,000 folks had enrolled. So we learned that voluntary doesn't work so good. Not if we really want to accomplish the things related to overall quality change and real savings. So we moved to a mandatory primary care case management program, but found, and there's some other information that I'll show you to affirm this, that actually it really didn't save money. In fact, we were growing at a double-digit rate year over year in the early 2000s when we had this program. And our experience was that actually some doctors were dropping out because it created some administrative hassles for them. We actually had them doing some utilization management. In other words, authorizing certain services, which is different than some programs, even more aggressive. So in 2006, after this conversation with our governor, we decided we're going to go this way. We're going to do Georgia Families, which is our full risk managed care program, what we called an enhanced primary care case management, and then the Georgia Medical Management Program, and I'll talk about those a little bit as we go along. I'm going to go into a little bit of detail here about how we learned these things, but I wanted to really emphasize here that these were some things that we learned. And we learned this both from our own experience and from others. Number one, for us, doing pilots like the pilot we did in the late 1990s with managed care was really, it was kind of a waste of time. It really didn't do what we needed to do. We needed to do something big. We needed to make a big difference in people's outcomes in their health care, access for their health care, and the cost for the health care, and we really weren't accomplishing that with pilots. We also learned from our experience and from others that we needed to have a limited number of plans. I think you heard that from the gentleman speaking earlier about the Florida experience. It didn't just need to be a wide open all comers, as some places do, and it was primarily because we really believed that in the long run we were going to establish our longest and most effective partnerships with these firms that will come and help us do this if we had a limited number of them. Now, we did do it competitively. Again, I think the gentleman from Florida also emphasized that you want to make sure you're getting the best players to come and assist you as your business partners in doing this. We did that through a competitive procurement. You do have to ensure that your rates to the plans, and I understand this was a bit of the problem that you guys had before when you were doing your full risk program, they do have to be actuarially sound. That actually now is a federal requirement as well. Another important factor that we learned is you have to allow sufficient time for implementation. Some of the things that we did that taught us this, I mentioned the primary care case management. The University of Alabama actually did a study of both our PCCM program and Alabama's, and found several things. While it did improve some of the patient experience and the physician's experience, it really didn't save money. Actually, there were some places where actually access went down. I mentioned already that a number of docs started to drop out of our program because of the hassles they experienced with the whole part, the utilization management part. And then there were some other studies that I've listed here. I believe these slides will be available if you wanted to check those references. Please feel free to do so. So what we did in Georgia, I mentioned the 3 programs. We did the Georgia Families, which was our full risk managed care. We did not put all of our populations in. I would say now that the Medicaid director actually is considering doing that this next procurement cycle, but we'll talk about why. So we had our low-income breast and cervical cancer and our CHIP programs, basically. I think our refugees were also in there on the first round of this full risk managed care program. So it was roughly 70% of our population. As you know, or I think one of the speakers in the managed care panel here just a moment ago acknowledged that their You need to also have your age blind disabled populations in. Georgia hasn't done that yet, but I think you're going to see some pretty profound results in savings and so forth, even not doing that. So we've got 70% of our population in. It's roughly 40+% of our cost. We put the SSI adults, these are basically disabled adults and disabled children, in a voluntary enhanced primary care case management program. That program was canceled in 2010 because it wasn't performing. It was achieving some modest savings, but not the savings that were projected, and also did not achieve the quality outcomes. And the same way with the third program, where pretty much everybody else, the dually eligible and so forth, were in an administrative type of program. This was also an enhanced primary care case management, and likewise that program was also canceled for non-performance. So what does it look like today? Again, I think you'll see some similar themes that the gentleman from Florida spoke to. We limited the number of plans. In our case, we have about 1.1 million members. On any given day, we got about 1.6 million members in Medicaid and our CHIP program combined, and 1.1 million of that group is in the full risk managed care. We created regions, 5 regions originally back in 2006. We have the same 5 regions. I mentioned emphasizing having strong partners that will be with us for a long time, because we were looking for long-term results. We have the same 3 plans that we competitively selected back in 2005 and went live in 2006, same partners. All 3 of those partners now are statewide, and the state is toying with, right now our age blind disabled population is not managed at all. The commissioner's made it very clear that in the next procurement cycle, he will be bringing some of these population, not sure if it's going to be all yet, into the full risk procurement cycle. Our procurement cycle for this managed care, the risk-based managed care program, will start in January of 15. And that's, by the way, that's 10 years of contracting, which is almost unprecedented in the state of Georgia. Normally it's 3 years plus 2. But because they were doing such a great job and achieving the things that they needed to accomplish, those contracts have been extended now. It will be 10 years through 2015. Next slide. A couple of things about quality. Someone asked earlier about how do you measure quality. Actually, we've been using the HEDIS measures, which is kind of the standard, if you will, Reader's Digest gold star standard to measure outcomes, both for access and quality. You can see here that the state took the effort to measure both we call them CMOs, by the way. That's managed care organizations. We call them care management organizations. Very quickly, funny joke, sitting with Governor Perdue in 2005, and we're talking about using HMOs. He says, I'm not sure I like HMOs. And well, Governor, why don't we call them care management organizations? I like that a lot better. I'm sure that kind of politics never happens in Oklahoma. But anyway, so we've called them CMOs ever since. As you can see, with adult pre and post measures, they've done an excellent job moving along on many of the things that are important, like cervical checks and breast cancer breast exams and so forth. For people with mental health, it's very important for someone to have a follow-up outpatient visit after they've been in an inpatient stay. You can see that we've had profound improvement in that area. Next slide, sir. These are some of the children's HEDIS measures. These are primarily access measures. Kids, the very young children on the far left, getting in and getting their well checks early on, and then as the children get older, and then I think we've got some, yeah, I don't have my glasses on. The one on the far right are immunization measures for kids as well. Dental, very difficult to get Medicaid kids nationally into the dentist. And you can see that we actually now are far exceeding the national average of how many of our kids who should get dental care are getting dental care. Now almost 70% of the kids are getting in and getting their dental care on during an appropriate time frame. And that was a substantial improvement from where we were. Savings. This one was interesting. This was from 2004 through 2009. I've got some information for a little bit later on. But in the United States overall, the growth rate on the average annual growth rate per enrollee grew 2.3%. You can see in Georgia, we actually had on an annual basis a negative 2.7%. So not only did we not grow at a rate faster than revenue, we actually had a decrease in our costs. I put up there that same report. This, by the way, was done by CMS, Office of the Actuaries. It's not something we did or the state did. The next slide gives some other information that's similar on cost. This comes from, I'm sorry, I got to put my glasses on. That happens after 32 years of public service. All right, so this was done actually by the Southern Legislative Conference, Council on States, and they show, just to give you an idea, side by side, Georgia's cost compared both on a per capita and an average recipient cost, Georgia compared to Oklahoma. And then the next slide, this is more recent cost data, 08 through 13. This actually was prepared by the state. The blue line on the bottom is the actual per member per month cost for all of those that are in the full risk managed care program. Now, at the starting point of 2008, if Georgia's per member per cost for that same group grew at the same rate that CMS, Office of the Actuaries, said everybody else on average grew, we would have grown on the red line. Obviously, that didn't happen. You say, oh, well, nobody's ever really average. Okay, fine. The green line in the middle actually is the growth rate applied to the PMPM for the low-income groups that are in full risk managed care that we actually experienced with our other fee-for-service Medicaid members in the state of Georgia. So things like, oh, well, you changed rates. No, actually, we didn't change any rates during all of this. And so the important thing, actually, when you consider that, going to the next slide, in a 5-year period, Georgia projects that they've actually saved as much as $4.3 billion. Our Medicaid program is between $7 and $8 billion a year, and including our CHIP program. So to give you an idea of the actual percentage savings over what it could or should have been, it runs about 11% per year over this 5-year period. So it's pretty substantial. Someone mentioned earlier you could expect 5%. That's a good conservative number. Our actual experience in the past 5 years has been 11%.